Hey guys, so circling back to 3 and 4 additional projections, I checked the PowerPoint slideshow and the YouTube video I tried to generate and didn't look like I could get audio from either of them, so we are re-recording. All right, so our objectives, we are going to go over the chest anatomy one more time. We're going to go over the abdomen anatomy one more time. We're going to talk about general radiation safety protection practices. And then I'm going to explain the new positions and procedures that are involved in this summation of all the extra stuff about chapter 3 and 4. Okay. Image critique might not be available because these are typically more rare exams. So we might be able to discover a soft tissue neck. I'll take a look for it next time we're in image critique as a instructor-led image critique. I'll look for a soft tissue neck study, but typically that's the reason I set aside these particular projections from chapter 3 and 4, because these are the ones that no one ever does. I want you to know about them, but are you actually going to do them? I've never done like oblique chests in clinical practice 15 years, so I don't know of any technologist that has ever done oblique chest. Oblique ribs, sure, but not oblique chests. So anyway, here we go. With a review of the soft tissue anatomy, the lower respiratory tract starts with the trachea. The very top of the trachea is the larynx or the voice box. I think we covered that in the post quiz, cart before the horse. Okay. The trachea comes down until it bifurcates into left and right primary or main stem bronchi. Singular is bronchus. Okay, it's Latin. You'll get used to it. The carina is the hook-like cartilage at the very bottom of the trachea. Okay? So it's got a different shape than the rest. The entire trachea is cartilage lined, but it's mostly ring structures, ring-shaped bits of cartilage, and that's to keep the trachea open. Both the trachea and the esophagus are generally tubes, but the trachea has to have a rigid exoskeleton, and that's what the cartilage provides, a semi-rigid exoskeleton, so that it doesn't collapse on itself. The esophagus, when you're not actively swallowing, the esophagus actually collapses back on itself and there's no volume to it. Okay? But the trachea has to stay open. If the trachea doesn't stay open, then we get respiratory difficulties, because it is the pathway of air from your nose and your throat to your lungs. So, all right, so the bronchi immediately branch off into basically bronchial trees. So after the primary bronchus, there's secondary and tertiary bronchi, and then there's the bronchioles, which are the very, very tiny ends. And at the ends of the bronchioles, that's where you get the alveolar bundles. Okay? Now surrounding all of that is the pleural space, which is a double-walled serous membrane. It's got a little bit of fluid in between the two membrane layers, and that's for friction-free expansion of the chest. We need the ribs to glide past the lungs without friction, or else every time we took a breath in, we would tear our lung open, and that would not be a good design. So we need some slippery surfaces that can slide past each other, and that's what the pleural space is. All right, in the upper airway, we of course have the nasal cavity and the oral cavity. In back of both of those is the pharynx or the throat. The pharynx does have a top and a bottom section. The nasopharynx is the top section. The oral pharynx is the bottom section. Um, there's a hard and a soft palate separating the nasal cavity from the oral cavity. And then as we get to the bottom of the oral pharynx, we come across the epiglottis. Epiglottis is just a flap of muscle. It is tethered to the same, a flap of skin that acts like a garbage can lid for your trachea. And so the epiglottis is tethered to the same muscle as the tongue is, and when you start to swallow, all right, your tongue does like an automatic motion where it pushes the bolus of food down into your throat, but at the same time as the tongue is flexing like that and moving the food to your pharynx, the epiglottis is also being stimulated to shut down over the trachea, or at least that's how it's supposed to function. People who have had a stroke, the epiglottis sometimes does not get closed quick enough, and they could get minor aspiration of food boluses into the trachea. Okay, and so we do swallow functioning studies on them. To document that and to see what textures of food they can still eat after they've had a cerebrovascular accident. Okay? But normal operation, when the tongue flexes the bolus into the pharynx, the epiglottis will slam shut over the top of the trachea. Beyond the epiglottis, that's the entrance to the trachea, and at the very top is the larynx or the voice box, and the vocal cords actually are across the trachea. They go across the trachea, kind of like guitar strings over the aperture in an acoustic guitar. And that's also very much how we get them to vibrate, is those vocal cords vibrate by us passing air past the cords, and then the cords vibrate at a certain frequency, and then that becomes audible sound. That in combination with changing the way we hold our mouth and our tongue, and certain inflections, like you might notice that whenever you say the letter T, right, your tongue hits the roof of your mouth for just an instant. Okay. Also, the letter P, G, and B are similar motions, but there's subtle nuances between them. It's all the same push from the vocal cords, but then the tongue and the shape of the mouth do something different, and so we get different sounds. Okay. Now, below the larynx is the trachea proper. It's the actual trachea rather than the voice box part of the trachea. And the thyroid cartilage shows up. Okay, the thyroid cartilage is the Adam's apple. It's the bump that you can see on the front of a man's neck. Behind the trachea is the esophagus. That is. So let me phrase that to you in quiz question language. The esophagus is posterior to the trachea. The trachea is anterior to the esophagus. Okay. Now remember the Sandra Bullock clip from the medical emergencies. From the medical emergency, I'm sorry, there's a song playing over the overhead page system, and I don't understand. The Sandra Bullock Heat clip, the choking scene in the Denny's diner, she wouldn't have thought to do a tracheotomy. In fact, nobody ever would have thought to do a tracheotomy if the trachea wasn't anterior to the esophagus. Okay, so remembering the choking scene from the Sandra Bullock movie Heat with Melissa McCarthy, and it's hilarious. You need to go watch it. But remembering that scene, you can always remember that the trachea has to be in front of or anterior to the esophagus, because otherwise tracheotomies wouldn't be a thing, because you would have to slice through the esophagus to get to the trachea. So the trachea or the airway is in the front. Okay. Okay, our abdominal cavity, yeah, we're lumping all the anatomy together of chapter 3 and 4. The abdominal cavity is also surrounded by a double-walled serous membrane, among other things. But that is now the peritoneum, which is the name of that structure, also has substructures in its visceral layer. Okay, and so it's called the omentum and the mesentery. The omentum is a separate section of, it's like the superior section of the mesentery. It does exactly the same thing the mesentery does. It just does it with different organs. So the stomach and the transverse colon are supported by the omentum, okay, which is similar to the mesentery. The mesentery is responsible for supporting the small bowel. Okay. And so slightly different, because the mesentery also carries the nutrients from the small bowel to what becomes the portal vein, and sending those nutrients, bypassing the circulatory system, sending the small bowel nutrients straight to the liver for processing. So there's a direct connection between the small bowel and the mesentery and the liver. Well, there's a direct connection between the small bowel and the liver, and that's because a lot of the nutrients we absorb and a lot of the medication we take is not in its activated form. That is, it's not in the form, the nutrition or the molecule, if you will. In the case of medicine, well, in the case of both, the molecule is not in the usable form for your body cells. The organ that changes nutrition from digested absorbed form into usable form is the liver. The liver does that processing. And so the liver needs a direct pipeline from the mesentery to itself so that the nutrients can bypass the bloodstream. Otherwise, your nutrition would be filtered out as waste. Because it's not in the useful form. So it bypasses, the portal vein bypasses the rest of the bloodstream, delivers the nutrient-laden blood straight to the liver from the small bowel via the mesentery. The omentum really doesn't participate in that. So that's why there's a difference between what we call the omentum and the mesentery. Okay. Once your liver processes the nutrients and the medications and such, it does turn them into the active cellular form, and then it just dumps those onto your bloodstream, and then you can make use of those molecules for rebuilding tissue or replicating new cells or fighting infection or relieving pain or whatever it is you ingested. Okay. All right, so the liver superior, the stomach. Now that's a strange view, because we're going like mid-coronal, so that's like the lower half of the stomach. The upper half of the stomach is actually at the diaphragm. So the fundus is actually at the diaphragm. The pyloric section, the pyloric antrum, which is what is shown here, is below the liver. Okay. The pancreas largely sits behind the stomach, but some people say underneath the stomach. Okay. The transverse colon underneath the stomach, layers of the small bowel. The small bowel contains 3 sections. Those are the duodenum, the jejunum, and then the ileum. Okay. And then the large bowel has a ascending, a hepatic flexure, transverse colon, descending section, splenic flexure next, then descending section, then sigmoid colon, then rectum. Okay. And then, yes, reproductive organs do vary. It's on the bottom of the drawing there. We're all adults. So for abdomens and patient preparation, typically you're worried about artifacts around the waist and also piercings if they'll remove those. But most notably around the waist. Everyone hopefully is wearing pants to the x-ray department. And pants have rivets and zippers and snaps and buckles and belts and belt loops, and even sweatpants have the little eye holes, right, for the drawstrings to come out. And then sometimes the drawstrings are clamped at the end, with that little pressure seal that makes the drawstring small. And sometimes those are metal too. So all sorts of probability. And then, of course, the joke I made in when we were learning the upright abdomen, men over the age 40 are required to carry a set of keys, a key ring that has at least 6 keys on it. Okay, depending upon what their role in society is, but you can pretty well guarantee that there's going to be 6 keys on a key ring in a pair of pants pockets. Okay, and so some of the techs take shortcuts and they just kind of have them lay down on the table, cover them up with a sheet, and then to have them drop their trousers. Be absolutely certain that the pockets and the belt buckle are out of the pelvis, okay? Because the keys will show up, okay? Now, the other joke about old men is if the man is old, and that's defined as over 40, he's going to have 6 keys in one of his pockets. Now, if he's completely gray, right? If he's gone completely gray, he's going to have $8 and change in his other pocket. I think it's to balance the keys when he walks so he doesn't topple over. That's my theory. I'm sticking with it. Okay. All right, your exposure technique, the book is recommending 85 at 25. That's a perfectly reasonable technique. You may find that on a DR plate, you can get away with half that mass, so like 12.5 or 14 mass at 85 would work just fine. Image receptor, typically for a KUB, you're going 14 by 17 field. Sometimes you're going upper and lower crosswise, and I taught you how to do that already. Source to image receptor distance, SID, is always 40 inches. ID markers, yes, the abdomen does have a difference between the left and the right. The liver is usually found on the right, not always, but usually. Radiation protection is kind of a wash, and that's what the American Association of Physicists in Medicine say. And so radiation protection, this is the only chapter, abdominal pelvic radiography, where we say, you know what, forget about the shield for this one. Every other x-ray exam, we should at least make an attempt to shield. But abdominal pelvic radiography, shielding is a wash. What does that mean? Well, that means it makes the physicists have gotten together, they've studied it, studied the data, taken some x-rays on phantoms with some radiation detectors embedded in the phantom and outside the phantom. And they did a big study, and the study said it makes no difference whether you put a shield on a patient for an abdomen x-ray or not. Okay? Now, what did all the techs hear? We don't have to shield anymore. That is not the case. That is not what they said. They said for abdominal pelvic radiography, shielding doesn't make a difference as far as the dose to the gonads. That's what they said. That is way different than we don't have to shield anymore because the physicist said so. The physicist did not say that. You need to go back and read the paper. I've got a copy of the white paper just in case anybody needs it for citation or reference, or if any of the staff techs want to. Always an open invitation for the staff techs to come and debate me about what I say versus what they say. All right. Patient instructions. Now this is tricky because this textbook does say, even though they have a separate chapter for GI fluoroscopy later, they say if your patient is getting a fluoroscopy study where they're drinking barium, because they do that for the cardiac series as well. If it's for the abdomen and it's ingestion of barium, there is going to be a preparation. And that's usually 24 hours before we even start the exam. There's some kind of preparation. Now, is it always clean the colon all the way out? No, that's just for the barium enema. For an upper GI and a small bowel follow through, the instructions are don't eat anything after your evening meal. So the night before, and it might even be clear liquid diet for the evening meal. So the day before your exam, your upper GI or your small bowel, you won't be allowed to eat solid food for dinner. You can have a big bowl of Jell-O, no fruit, big bowl of Jell-O, and you can have water to drink, no milk. Milk is a protein. It's not really a clear liquid. You can have water, you can have Kool-Aid, you can have sweet tea, you can have coffee, but coffee and Jell-O do not mix. I would suggest the water myself, because Kool-Aid, you're going to be super hyper from all the sugar if you have Jell-O and Kool-Aid. Okay, and same for sweet tea. Sweet tea creates diabetics. Don't drink sweet tea. Okay, but enough about that. The point of this is, even though we're not talking about GI fluoroscopy, sometimes there is bowel preparation for some abdomen studies. Typically it's those that involve the ingestion of barium. Okay. All right, there you go. Controlled diet, laxative, enemas. Okay, so yeah, sometimes a laxative. Typically the laxative and not always, but typically the laxative and the enemas, that's a little bit more aggressive, and we usually only need that for the large colon, not the small bowel and the stomach. Not always. Some doctors will have you take, for a small bowel follow through, they'll have you take a laxative. Okay. Everyone gets the controlled diet, nothing to eat after 6 p.m. the night before, and sometimes that's a Jell-O dinner, clear liquid diet for the dinner meal the night before. Okay. Patients, so when do we not do a bowel prep? When we have a suspicion of perforation or rupture, that is, the colon has split open, okay, or an obstruction. We don't do a preparation then, okay. So sometimes, yeah, so this is like a footnote to a footnote. When we're doing an abdomen study that involves drinking barium or getting barium into the large bowel, we are going to do preparation, unless it's an emergency, and then we're not going to do preparation. All right. SID, as we just mentioned, always 40 inches for the abdomen. No reason to shoot at 72. We're not trying to reduce magnification for anything. Your eye, oh, that's a terrible background. I just noticed that. That's low contrast. Hope you guys can see it. If you're having trouble seeing that, that might be a sign of color blindness. It's borderline for me. I do have just a little bit of color blindness, but I can see this. So right or left side markers must be included on at least one of the projections on an image receptor. Yeah, that's if you're doing multiple projections on an image receptor. We don't do that anymore. So every exposure should be marked. You can go back and mark with digital annotation, but that does not meet the legal standard for an X-ray image. Yes, there's a legal, an X-ray image is a medical legal document. Okay, even in an electronic form, it's a medical legal document, and one of the requirements of a valid medical legal radiograph is a radiopaque marker was placed in the exposure field at the time of exposure. Post-processing marking is subject to fabrication. Let's just put it that way. Okay. Other required ID markers must be in the blocker. What's the blocker? Well, it's basically the corner of the image reserved for demographic information. All right. Shielding patients. Refer to the guidelines on page 33, 34. Hopefully, in the new version, they'll talk at length about the AAPM. I want to look that up. I'm going to pause that and make sure they 33, 34. Give me just a second. Okay, so it's there, but the pages are wrong. That's actually in chapter 1. They actually address that on page 24 and 25 of chapter 1 in volume 1. And what they say is the various governing bodies, American College of Radiography, ASRT, ARRT, National Council on Radiation Protection, issued a statement in January 2021 recommending that gonadal shielding be discontinued for abdomen and pelvis radiography. Okay? In light of this most recent evidence, the shield gonad statement from chapters 4 and chapter 8 have been removed. And so you need to be aware of the new guidelines, okay? We only need to shield patients for extremities, chest x-rays, and everything except for abdominal pelvic radiography. In addition to shielding, we can collimate to the area of interest and use the correct technical factors, the ones that are proven to have worked before, so that we're not just guessing at technique, because guessing at technique leads to repeats. And so both of those in the bottom, no one said anything about those. So you can collimate to the area of interest, that is just the abdomen, especially your hypersthenic patient. You don't need, just because they have 4 to 6 inches of adipose tissue does not mean you have to radiograph it. Okay? It's not adding any information to the study. Okay? So collimate appropriately and use an optimum technique. And then that limits the amount of tissue that is actually exposed to radiation, and then also limits the number of times that you expose the tissue to radiation. Both of those are effective radiation protection practices as well. All right. For your patient instructions, make sure you tell them what to do with their arms. Okay. Give them specific instructions for their arms, either at their side or above their head. Exposures for abdominal procedures are made at the end of expiration to avoid compression of the organs. See what I mean? It's on the quiz. Expiration and hold for all abdominal radiography. All right, now let's go into the chest x-ray, not the chest x-ray, Let's go into soft tissue neck and oblique chest and decubitus chest. All right, so soft tissue neck series is an AP and lateral. It looks a lot like a cervical spine. You're just going to mess with the technique so that you can enhance soft tissue. We're not really interested in the cervical vertebrae. It's the same chunk of flesh, so to speak, but the area of interest is shifted from the vertebral bodies and the vertebrae themselves to the trachea in particular. That's probably the most notable portion of a soft tissue neck. So when do you do a soft tissue neck? When your pediatric ER patient has croup, that's when you do a soft tissue neck. So croup is, moms will know, but croup is swelling of the lining of the trachea, and it actually bottlenecks and stenosis. It kind of kinks in on itself. And when it starts doing that, if you take in air way too fast or push air out way too fast, you can actually get a barking sound like a seal, like a art, that kind of sound. Well, that's croup, okay? And croup is dangerous because the only way you make that sound is your airway is partially collapsing halfway through you pushing air through it, okay? And so the soft tissue neck AP and lateral study can diagnose croup. It can tell us if we have tracheal or epiglottal swelling or inflammation, okay? Epiglottitis or croup, all right? Your PA obliques, your anterior obliques, those are going to be for the chest, for the cardiac series. And then instead of a PA, sometimes we do an AP and an AP axial. So the AP axial mimics the PA. It looks very similar to the PA. But a straight AP is like for trauma. All right, so first the trachea. Well, how much do you want to see? So different sites are going to have different protocols. You're either going to image the entire trachea, which would be all open center at the manubrium, open up the collimation to fill a 12-inch cassette, and then about 4 or 5 inches wide side to side, okay? If they only want to see the trachea above the chest cavity, then you can center for like C4, cervical vertebrae 4, the thyroid cartilage or the Adam's apple or equivalent. So the centering varies according to site protocol is basically what I'm telling you. I don't think anyone is going to scream at you if you always see, if you do this one that's pictured with a young man in the top, centered at the manubrium and then opened for the entire run of the trachea. I mean, no one's going to fuss at you for that. That's a nice, thorough job. They might fuss at you for the other kind where you just stop x-raying and don't follow the trachea all the way down. Especially if it's a swallowed foreign body, you really need to capture all the trachea. So playing it conservative, if I were doing this and I didn't have any guidance from my protocol book, I would do the top one, not the bottom one. Okay, I'd capture the whole trachea. It's just safer. Okay, for our lateral trachea or lateral soft tissue neck, it kind of looks like a cross between a lateral sternum and a lateral C-spine. We want to like lace the fingers behind our back and puff the shoulders backwards, like flex the shoulders posteriorly, puff the chest out, kind of like a soldier standing at attention. What that's going to do is the anterior structures of the lower neck, the trachea, and the sternum are going to flare out in front of the shoulders, and we'll be able to see them free of superimposition of the humeral heads. Now again, where do you center? You're doing no harm by centering again right at the manubrium. and opening the collimation to the bottom of the jawline and then down to where you think the trachea bifurcates, which again is roughly T6 or so. So the bottom of your image kind of looks like see where the bottom of the light is crossing? It kind of looks like it's intersecting round about T7, about halfway down his sternum. That's roughly where the trachea ends. So if you do miss the bifurcation of the trachea, you probably should repeat for this. Breathing instructions for this, you want your patient in the middle of inspiration if they're capable of it. Again, sometimes the reason you're doing this is foreign body obstruction, like a child swallowing a quarter. So skip the breathing instructions if it's for obstruction, foreign body, because if it's blocked, they won't be able to obey your instructions anyway. Okay. But all others, even the ones with croup, you want to be on the rotor and you want to say, okay, now take in a breath. And as soon as you see the chest start rising and they're understanding your instructions, mash down and hit that exposure switch. Don't worry about the motion or artifact. It'll be minimal. You want to get an air-filled trachea. That's the key to this study. Okay, your oblique chest side of interest farther from the IR. Okay, that is the exception, not the rule typically. And there's a reason they pointed that out and they made it italics. I think Haley was it. I think it was Haley that asked a question about that previously when she was reading the chapter. Yeah, side farthest from the IR is the area of interest for oblique chests. But that's a bit of trivia. All of oblique chest radiography is a bit of trivia because no one ever does them anymore. So there is a thing called a barium cardiac series, and the barium cardiac series requires steeper obliques than a 45 degree. A 55 to 60 degree oblique position is required. Okay, and that's because we want the heart to be evenly split between left and right side. Okay. And then we have the patient drink barium during the exposure too. Yeah, it's really weird, and we've got CT scanners now, so you never see these studies anymore. I've never done one myself. But it is a registered question, so we still teach it. Okay, so for your oblique chest, typically if you're getting oblique chest, you're going to get 45 degree angle oblique chest. Only in the case when you know specifically you're doing the barium cardiac series, will you do a steeper 55 degree to 60 degree oblique. Centering for an oblique chest as far as versus the image receptor is about the same. And that's because just because you turn somebody doesn't mean their lungs change height from the floor. And so if the top of the image receptor for a PA chest straight is 1.5 to 2 inches above the vertebra prominence or the outer margin of the shoulder when relaxed, then it will be that way for an oblique chest as well. Now, as far as the arms go, you are going to get skin artifact if you leave the arms straight down at their side. Typically what someone does for an oblique chest or oblique ribs is you raise the arm closest to the image receptor. And so if you're doing an LAO, the left arm would be raised up and the right arm would be like chicken wing posture, hand on the hip, right elbow flexed and away from the side of the rib cage. What you're doing there is you're removing superimposition of the soft tissue of the arm onto the rib cage. That's what you're doing. All right, so there's a PA oblique. Is this an LAO or an RAO? This looks like that's an LAO. Yeah, that's an LAO. Patient's left anterior is closest to the image receptor. Okay. Breathing instructions, same as a PA chest, expose after second inspiration. The central ray, it's gonna be weird. There's the central ray. You know how we had for the PA, it's mid-sagittal plane and T7. Well, the central ray is going to shift off of the mid-sagittal plane now because you've obliqued the patient, but it's still going to be at the level of T7. Okay. And then again, remember cardiac series, steeper oblique than a 45. Okay. So that's for the PAs where site of interest is furthest from the IRs. For the APs, site of interest is closest to the IR. That's the first time I've seen the language dependent side versus independent side, but it makes sense to me. So you might see that dependent upon which question, which author, registry exam, they might say the dependent side versus the independent. They just mean, for the dependent side, they mean the side closest to the image receptor. Okay, it's dependent upon the image receptor for support, if you want to think of it that way, versus the side away is independent of the image receptor. All right, so for your oblique chest, you can lay them down, you can stand them up. It's a 45-degree oblique. You won't be doing a cardiac series AP with an AP oblique because that's too much magnification of the heart. And so the cardiac series is only for the posterior obliques. Or I'm sorry, only for the LAO and the RAO. That's more specific. There you go. Okay. Centering, same. Okay. 3 inches below the jugular notch. That's roughly T7. Okay. Expose on second full inspiration. Again, nice full lungs make for a better chest X-ray. For our AP chest, when are we going to do this? We're going to do this when the patient is unconscious and it is dangerous to sit them up straight because their monitors start going crazy when you do. Okay. So you'll see this like trauma MVA or heart attack. If the patient arrives unconscious from the ambulance, you're going to be doing a supine chest X-ray. You're not going to be leaning them up into a semi-Fowler's position. You're going to do a flat chest X-ray. Okay. Now, that being said, the flat chest X-ray is usually done portably in the trauma wing of the emergency department, or in the critical bays of the emergency department. That's when you see a flat AP chest X-ray. It is going to look so alien to you. The clavicles are going to look like they're wrong when you shoot a flat AP chest. Okay. The patient will be, I bumped the microphone, sorry about that. The patient will be supine, and we only use this one when we're desperate and it's not safe to tip the patient's head up into a semi-Fowler's or Fowler's position. Hey, look, it's the same centering. It's as if the lungs are always found in the same place. How about that? Okay. You do want to flex the elbows, pronate the hands, place hands on hips to draw the scapula laterally. Yeah, if the patient can roll their shoulders forward, by all means have them do that. You're removing superimposition. Make sure they don't introduce rotation when they do that though. And they do it even, some people have bad shoulders or one bad shoulder and they can't quite get the motility that they do in the other. So just be mindful of that. Okay. The central ray is directed perpendicular to the sternum, and it does enter 3 inches below the jugular notch, which I think you'll find is T7. I really like halfway between the xiphoid and the jugular notch better than 3 inches below the jugular notch, but that's me. I think the halfway point of the sternum is a better landmark than a 3-inch measurement. Okay? And again, get nice fully inflated lungs if you can. Right, our lordotic position, I do need to take give me just a second. All right, so our lordotic position, sorry, I had to take just a little break. Our lordotic position is an axial chest with, typically it's the patient leaning back, but you can also do it with an aggressive cephalad angle if the patient's standing straight up, okay? You typically want something on the order of, I would say that looks like 20 degrees, 15, 20 degrees cephalad angle if the patient's standing straight up. If the patient can lean back like this, that's usually the better result because you still get a horizontal beam and therefore an air fluid level. The lordotic chest is advantageous for imaging the apical regions of the lungs because the clavicles are they are displaced superiorly to the apical regions on a lordotic chest. And it looks kind of space alien-like when you do that. So we still want to place the image receptor roughly the same 3 inches above the shoulders when the patient is in lordotic position. Okay. Assist patient to lean backwards until shoulders rest on the image receptor. Alternatively, you can have the patient stand up straight and use an aggressive cephalad angle, 15 to 20 degrees cephalad will also get you a lordotic chest. Okay, just make sure you're adjusting the IR to above the patient's chest to catch the exposure because you're going to be throwing the shadow upwards toward his head. We're going to center, of course, to the image receptor, but and if we're making the patient lean backwards, it is going to be a perpendicular central ray. Mid-sternum is roughly the area. The thing you don't want to do is clip the apices because the apices is a region of interest. So as long as you have the apical regions on there, it's going to be a good radiograph. Okay, mid-sternum should do. Hey, in gravitational fields, here's a quiz for you. Liquids always flow downhill is the right answer. Yes, so liquids will always appear to seek the lowest position in a gravitational field. Air, being less dense than solids and liquids, will always move to the elevated position or the high ground. And so pouring a glass of water and the way that orients, that's not an accident, that's physics. That's liquids and gases orienting themselves in a gravitational field. The photoelectric effect is more likely to occur when the mass density, that is, number of molecules per cubic centimeter, is increased. And so water is more dense than air. And we already did this experiment. Okay? And so the water absorbs the X-ray while the air does not. We get a nice air fluid level. Okay? This is a precursor to teaching you about what is this dark band called? Why are things dark? The dark band's called the meniscus. As to why it's dark, wrap your head around that, because that tells you something about the nature of light. Okay? And so you might have heard a philosopher, this is a Buddhist saying, but it's also a scientific fact. Darkness is the absence of light. And that is absolutely true. Darkness is not a physical thing. It's not made up out of anything. It's the absence of photons in the environment. Once you add light photons to the environment, darkness disappears. Okay? So, what does that tell you about the meniscus? Why is it dark? There's no photons coming through right there for whatever reason, right? And then you have to start asking about, well, what is it about an air-fluid boundary that makes it so I can see photons coming through the air, right? Because the glass is see-through and the glass plus air is see-through. And then I can see through the water plus glass. But at the meniscus, I can't see through that part. That's dark to me. So no light photons are coming through exactly at the meniscus. What's happening there? That's weird. See, this is the type of things that I think of. That, I mean, how many times have you seen the top of a glass of water? Right? You filled a drinking glass. Have you ever thought about that? Why is that showing up dark when the rest of the glass appears clear? Doesn't that seem odd to you? What is so special about that air-fluid boundary that all of a sudden the photons aren't appearing there or not getting all the way through that structure? Every other structure, except for the base of the glass, but we can explain that. That's a little bit thicker. But the water at the air fluid boundary is about the same thickness as the water everywhere else in the glass. But at the air fluid boundary, it's suddenly dark. It's opaque. It's strange. Anatomy, lungs. Oh, yeah, I do know the answer to that. I'm not telling you. I want you to. I want it to, like, play with your mind. I want you to wrestle with it. What the hell is going on there? And then I want you to look up on the internet and read about electromagnetic waves and light. See if you can figure out for yourself what the hell is going on there. Okay? Respect the process. All right. All right. So I think I went over this at the beginning. So, yeah, visceral, pleural, parietal, pleura. Bronchus, yeah, we went through this. This is a duplicate slide. So, yeah, just chew on it again. Repetition is the key, but you can do that by yourself. I'll just sit here for about 10 seconds or so. Yeah, okay, good. So, yeah, make sure you know this anatomy. It will come up on a quiz. Okay. Who gets a decubitus view? Well, the reason we do a decubitus view is so we can see an air fluid boundary. That is, lay the patient down and shoot with a horizontal beam. Okay? And the reason we want to see air fluid boundaries is because it's radiographic confirmation of the presence of either air or fluid. Okay? And so a lot of our pathologies, edema, ascites, free air in the abdomen, pneumothorax, that's PTX, pneumonia, hematoma, effusion, and infiltrate, all of those are air or fluid-based pathologies that we can find either in the thoracic cavity or the abdominal cavity. And so we do decubitus views and upright views so we can detect air fluid levels, because air fluid levels are a radiographic sign. And they tell the radiologist that there's an air pocket there, or there's a collection of fluid there, or there's both there. And then that leads them to the conclusion of it might be one of these pathologies. Yes, pneumonia forms a meniscus. All right, so we've covered, did we even cover the projection of the chest? Okay, lay the patient down, left or right. This is all screwy. Lay the patient down, left or right. You know what? I'll cover it. I'll cover it in demonstration. I'll do it in lab. Okay. Here's our projections of the abdomen, decubitus left and right. We prefer a left lateral decubitus. Um, when the patient's too ill to stand or sit upright for an upright abdomen. Okay. Left lateral decubitus is the more diagnostic of the two views because if there is peritoneal air, it's going to be a high contrast sign against the gray of the liver. Okay, so think about what we have in the right upper quadrant versus the left upper quadrant. All right, try not to be distracted by the skinny man. Man, talk about needing some steak and potatoes. That guy, they must have dragged him from Europe. He's too skinny to be an American. Anyway, in the right upper quadrant, we mostly have the liver, and that's about it. It takes up all the space. In the left upper quadrant, we have the spleen, which is smaller than the liver, the stomach, which could possess air. That's key. And the splenic flexure, which also could be in possession of air. So 2 out of the 3 things that we find over on the left upper quadrant could hold an air bubble as part of just their normal function, right? And so the liver never holding on to an air bubble, we know that if we see an air bubble in the proximity of the liver, like between the liver and the rib cage, then that has to be a peritoneal air bubble, and that's free air in the abdomen, or pneumoperitonitis or some such thing. That's a radiographic sign. If we do a right lateral decubitus and we see an air bubble, well, the radiologist is not going to be able to tell if that's a peritoneal air bubble, a splenic flexure air bubble, or a stomach air bubble, because all of those things could be going on, and so we don't get a definitive read. You see? And so what's the preferred? The preferred is upright. But if the patient's too ill to stand upright for an abdomen x-ray, you have to do a left lateral decubitus. Now, typically the abdomen is wider at the top than it is at the bottom, and so the air bubble is going to drift to like the upper quadrants if there is an air bubble in the peritoneum. So we still center like it's an upright abdomen, 2 inches above the iliac crest to capture the diaphragm. Okay, we're not really expecting air or fluid-based pathologies all the way down near the bladder. Right? Typically, when we're doing a decubitus, it's to capture air contrast, free air versus the liver. Okay, and there's an example of free air versus the liver right there. See that little black stripe on the top? Yeah, that's it. Okay. Vertical grid device, yeah, you will be generating enough scatter to justify use of a grid, so you'll need to put on one of those slide-on or snap-on grids for a decubitus projection. Center the grid to the intersection of the mid-sagittal plane and 2 inches above the iliac crest. In other words, put the gridded cassette in a location where it's going to catch the x-ray coming out the patient if you're already centered to mid-sagittal plane and 2 inches above the iliac crest. Okay? A lateral abdomen, you very rarely see this, but it's very similar to a lumbar spine, 2 inches above the iliac crest, and centered to the mid-coronal plane. Okay, flex the knees for support and comfort. Your geriatric patient, if you don't flex the knees and you roll them up on their side, they will not stay up on their side. Okay. You can also use rolled sheets or angle sponges to support them tucked behind their shoulders. Try to keep the angle sponges out of the radiographic field. Okay. Lateral abdomen is extremely rare. I think I only shot one in my entire career, and that was for cellulitis of the anterior abdominal wall. It was positive. We found it. So, yeah, here's the lateral abdomen. Yeah, mid-coronal plane, 2 inches above the iliac crest. Okay. Not very diagnostic, y'all. It doesn't add much, unless, I mean, for the one that I did, I didn't actually center at the mid-coronal plane. I cheated forward an inch, and I shot it for soft tissue, like a knee, so that I could get under penetration of the abdomen, but adequate penetration of the abdominal wall. And we saw carbon dioxide bubbles in the subdermal layer, and so we knew it was cellulitis. All right. A dorsal decubitus projection just means you're laying the patient on their back, and this is for when you have to do a lateral abdomen, but you can't get the patient up on their side. Okay, and so ultra rare right here. Okay, and that's what it looks like right there. Same centering, 2 inches above the iliac crest. Make sure you're telling them where to place their arms. Don't forget that, arms above the head. Okay, and crossed on the upper chest or behind the head. Behind the head is better because it also gets the elbows. The elbows can be in the way of the diaphragm if you cross the arms over the chest. Okay. And here's what that one looks like. Adjust the height of the grid to align with the image receptor with the mid-sagittal or mid-coronal plane. Yeah. Yeah, you want them centered to the image receptor, the body part. So center the central ray to the body part, and then center the image receptor to the body part, and then the central ray will be centered to the image receptor as well. Okay, line up object A with object B with object C. It's the same. Just because you're shooting horizontally, the equation hasn't changed. X-rays are still traveling in a straight line. They're just doing it horizontally rather than vertically. Okay, so if you shoot them at a certain trajectory through the patient, you have to catch them on the other side with the image receptor. It's just, that's the easiest way to think about it. I have to catch what I shoot. Hey, which one of these will demonstrate a pneumoperitoneum? Upright AP projection, left lateral decubitus projection, dorsal decubitus, or all of the above? The right answer is actually all of the above. You'll see on a dorsal decubitus with a patient lying on their back, a pneumoperitoneum will go up under the rectus abdominis and the anterior abdominal wall, and so you'll see it there. Okay, but all three of these can show free air in the abdomen. Hey, what position are we in? How do we name decubitus positions? We name decubitus positions by the side that is supporting the body, the side that they're laying on. So you see the little radiopaque right and an up over here? That means left side down. That means left lateral decubitus. Okay? So the decubitus positions are named according to the side that the patient is laying on. A dorsal decubitus, they're laying on their back. A left lateral decubitus, they're laying on their left side. And we get that nice, look at that nice high contrast air versus liver right there. And then the thin white line outside, that's actually the abdominal wall out there. So nice little air bubble right there in between the liver and the abdomen wall on that top right side. So air always seeks out the high ground. Water always seeks out the low ground. I can't believe I skipped over the talk of the chest X-ray position, the chest decubitus positions. That's okay. We'll get the hang of them in demonstration. We're gonna do a practice lab of all these and the soft tissue neck coming up. So, all right, here we go. That's the end of that. Radiation safety. Remember, we can't shield abdominal pelvic radiography. Well, not that we can't. We can, but we know definitely we're going to cover up pertinent anatomy. And then the physicist did say that it doesn't make a difference if we do shield. So those two things, we don't end up shielding abdomen x-rays. So be mindful of that. All right. Y'all take care. Have a good weekend. I'll see you.